Good afternoon, all. So, hope I am audible and visible too. So, today we are going to discuss one important topic, that is artificial intelligence in diabetes. So, it is very important to understand that our healthcare ecosystem is fragmented. Siloed providers, no unified data. These are unfortunate reality. And when we talk about any chronic disease management, adherence is an important area. Behavior change tools remain underused. Now we are talking about M-health or mobile health. But again, there are many gaps if we talk about adherence. Apart from that, yes, we have shortage of specialized diabetologist. And another important area is monitoring fatigue. So there are many data, but not enough insight. So in that background, what we can conclude, diabetes is complex, data heavy, and demands continuous vigilance. There, artificial intelligence excels. So if we talk about artificial intelligence, I think many of us had gone through this type of slides. So artificial intelligence is an umbrella term. So this is a broad field of creating machines that mimic human intelligence, could be perception, reasoning, learning, and decision making. Now, when we talk about machine learning, it is like an engine. So a subset of artificial intelligence where machine learn from data to make predictions or decisions without explicit programming. And in more detail, if we talk about deep learning, which could be a turbocharged version of that engine. So this is one type of machine learning which use complex neural networks with many layers to process complex patterns in large data sets. For an example, it could be also image, speech. Now we are talking in this Zoom platform using AI companion. So my speech had been utilized by Zoom, and there they are using deep learning. So when we again were talking about traditional workflow in our day-to-day clinic, there is one patient, we got some lab report, and then with that clinical examination plus lab report, we decide about diagnosis or plan. But when we talk about artificial intelligence in this workflow, we are not talking artificial intelligence as an alternate intelligence, alternate zone of therapeutics. Rather, we are talking about augmented intelligence, which could augment our workflow. So with patient, the lab data, we are now also having one companion which could be considered as artificial intelligence doctor. And both of us have some interaction, and therefore we reach towards more precise diagnosis and can plan precisely the therapeutics. So we are more going forward towards precision medicine. So again, we need to reiterate, artificial intelligence does not replace the doctor. It empowers the doctor with deeper insights and in a faster way. So artificial intelligence is not equal to automation. So it is augmented clinical intelligence, amplifying the human expertise with some predictive data-driven support. As we are talking today about diabetes and artificial intelligence, there are multiple areas where artificial intelligence can help us, starting from personalization in diabetes management. It could be insulin dosing, to public health intervention. We can develop tools for assessing or preventing diabetes complications. We'll discuss few of those tools in next few slides. Then how artificial intelligence can customize our dietary or lifestyle advices, so we can reach the precision nutrition, precision lifestyle advices. And also, it could enhance the clinical decision making, because artificial intelligence informs and refines healthcare professionals' decision in many ways. And most importantly, as we are having today different chatbots, we can engage patient into the loop, and we can promote self-management, rational self-management. So different artificial intelligence tools can boost patient involvement in diabetes care. Next, with these artificial intelligence tools, we could have different research models, especially predictive models, which could predict or forecast the diabetes progression and treatment response. Next, it could also enhance the health monitoring system, especially we will talk about continuous glucose monitoring. So it enhances real-time glucose monitorings. It will give us alert. It can predict hypoglycemia early. And artificial intelligence also improve in diabetes-related medical imaging, be it our a picture of retina, and we will discuss one very novel research who are taking the picture of our face with some 12 megapixel camera and can predict diabetes. And therefore, what we can say, there is no alternative to artificial intelligence nowadays. If we are going to treat our diabetes patient, we need to take help from artificial intelligence, but it is not alternate to us. So we should be in the loop very much, and we can use this augmented intelligence for the betterment of our patient. So as we are talking about artificial intelligence, I think this is a very important model that I want to emphasize, because this is one, we can say, Make in India, part of Make in India project, the twin health technology. So this is a very fantastic artificial intelligence driven model, which can tell us one individual's metabolism. So we are talking about whole body digital twin. So they will collect daily signals using different sensor data, blood parameters, medication data, behavioral data, food data, nutritional data, and also the socio-economic data. And therefore, with all this data, they will give us a picture of one artificial intelligence derived digital twin model, where we can locate the problems in the metabolism, and according to that, we can decide upon the precision treatment. It could be precision nutrition, precision medication, precision sleep, precision activity, and precision breathing also. So whether this is actually having some data, I think yes. So this is a very fantastic study, randomized controlled trial of 1 year done by Dr. Shashank Joshi. So their team had uses continuous glucose monitoring plus sensors, wearables, and logs to model users' metabolism. And then what are the finding of this randomized control trial? In the digital twin now, there were minus almost 2% HbA1c reduction compared to the standard of care. It was only minus 0.2%. Weight loss was there around 7.4 kg plus minus 6 kg. And that was statistically and clinically significant compared to the standard of care. And more importantly, more than 10% weight loss that was found in almost 42% of research participants who were in digital twin intervention. BMI reduction, waist circumference reduction almost 10 centimeter, and very important, the adherence rate was around 90% at 6 months. So digital twin innovation, what we can say, it combines both artificial intelligence plus human clinician oversight. This is again another important study using digital twin where the management of hypertension among this diabetes patient, how that is going to reflect. So this was again a 1 year randomized control trial. I was one of the co-investigator in this particular RCT. What we found, I think this was published in a very noted journal of JSUC. So this artificial intelligence enabled digital twin technology was more effective than standard of care in reducing blood pressure and antihypertensive medication. So we can see both the need of medication was reduced and also the blood pressure was reduced. And most importantly, it induced hypertension remission in a good cohort of population, study population. And normoalbuminuria remission also happened in participants with hypertension and type 2 diabetes. Again, another study by Paramesh Samanna, Dr. Shashank Joshi, and others, they had published in ADA update. So digital twin technology in type 2 diabetes remission and glycemic improvement. So it was a 18 months results from one randomized control trial. So that results were very much encouraging. Out of 233 digital twin participants, almost 207 completed a minimum of 6 months of intervention, qualifying them for remission evaluation. And most importantly, almost 65% achieved sustained remission at 18 months. So again, if we can see certain, want to check certain real world evidence study, retrospective real world study, we can see that had been published in scientific reports by Dr. Shamanna, Dr. Joshi, and others. So what they found it is not only the HbA1c is going down, but also the insulin resistance had been improved. So ultimately the beta cell function was improved. So CGM metrics, different parameters, they had shown they were improved. So we can conclude from this particular study, because whatever, when we talk about a randomized control trial, they may have very high internal validity, but in real world, how actually this digital twin intervention worked, this particular study, we can say a landmark in that regards. And in real world also, where very high external validity is there, so digital twin intervention could play a vital role in parameters like improving the insulin resistance, beta cell function, and the CGM metrics that had been improved too. The take-home message from this all digital twin studies: artificial intelligence plus clinician synergy. This fixed dose combination is very important. It is not only artificial intelligence or only clinicians involvement. So we need this synergy between artificial intelligence and clinician, which could help us to promote personalized and scalable care. Now coming to another area, that is bionic pancreas. And I think this was the first randomized trial of a bionic pancreas in type 1 diabetes. And after that, this bionic pancreas got approval in US. So what about the benefit? They had used artificial intelligence in there, and the key clinical benefits were more time in range, less hypoglycemia, and ultimately there would be less patient burden. So as we were talking, FDA approved silent bionic pancreas in 2023. So these beta bionics are approved in US. And as we are talking about closed loop system, the artificial pancreas, they have three important components. One is CGM, one is insulin pump. Now, one that is the very important component is also the artificial intelligence control algorithm. So adaptive machine learning based models. So what are the real-time application? Or we can say there could not be no need to have that carb counting or manual bolus needed. So we got this automation, which is not just automation, it is personalized metabolic control at machine speed. So CGM, they transmit the glucose data, and we have artificial intelligence algorithms. So they will predict and adjust the dosing dynamically. And then the insulin pump will deliver the insulin in real time. And we got again the feedback loop, the CGM monitors, and the effect of the loop continues. So the cycle will go on and on. So we got a closed loop system which is being powered by artificial intelligence. Most importantly, when we talk about this glucose prediction and monitoring stories, whether we can anticipate the unseen. I think artificial intelligence can help us to anticipate the unseen. Why this is important? Why predicting glucose value is important? Because we need to anticipate hypo or hyperglycemia to prevent complications. These are vital for nocturnal and pediatric hypoglycemia risk reduction. So if we have a machine learning component and continuous glucose monitoring together, it could help us as a powerful duo. So we need inputs from continuous glucose data, insulin dosing, meals, activity, and therefore we got a certain output like predictive models which will forecast blood glucose levels at least 15 to 60 minutes ahead. And that is why we can prevent pediatric hypoglycemia. Here we can see this model, especially if we talk about these machine learning models, which could achieve 90% accuracy in predicting hypo events in children. They may use those random forest model or artificial neural network or logistic regression techniques, but they will give us early warnings, which will lead to fewer or less emergency room visits, and ultimately we can improve the quality of life. So that is why when I was in IDF, there were a very good number of type 1D patients. They are coming for the patient advocacy group. And one of those patients, when just checking one HbA1c in a point of care setting, that there were one stall, and that time his HbA1c was around I think 6.1%, and he told, "Oh, I am not happy at all." I asked, why? Your HbA1c is 6.1 and you were type 1 diabetes. I was thinking like that. I just asked why, because he told, my HbA1c always for last 1 year, it was around less than 6%, around 5.4 to maximum 5.8. So I am frustrated why it becomes 6.1. So they have the AID, and that can help them to reach their goal without compromise in terms of hypoglycemia. In our setting, when we are using basal bolus, if it is near 7%, the fear comes inside our cognitive domain that maybe my patient is experiencing hypos. So that is the beauty. If we can add artificial intelligence, for an example here, the AID, that could predict and that could prevent hypoglycemia and help us to reach more time in range. So this is just an example how we can see in the real-time glucose prediction, that blue line is the actual CGM data. And if we use machine learning model, they can predict. And this almost, we can see the predicted trend dips 15 to 20 minutes earlier. So effectively forecasting the onset of hypoglycemia before it occurs. So we can prevent hypoglycemia. So this is the beauty of using machine learning predicted models. So the take-home message should be, artificial intelligence transforms glucose monitoring from reactive to proactive care. And as we were talking about some complications, I think diabetic retinopathy is something which we all know, and its impact. If we use artificial intelligence here, then we could have a lot of information. And I think there are various other ophthalmic disorders and non-ophthalmic disorders that can be identified, that can be predicted early if we use artificial intelligence. So this is a fantastic review article which suggests that for vision-threatening diabetic retinopathy, this deep learning system had an accuracy of around 94%, sensitivity of around 91%, and specificity of 95.4%. So if we again talk about the retina specialist, where the sensitivity accuracy is 93%, sensitivity is 84%, and specificity is 95.5%. So what we can conclude, the deep learning models, this system can deliver real-time diabetic retinopathy detection almost similar to the retina specialist. So this is why these are few studies we can see done by different researchers where we can go through this sensitivity and specificity. So coming to the first US FDA approved AI diagnostic retinopathy screening tool. This is the first practical point of care screening solution for diabetic retinopathy. And this had been approved by US FDA. They had used this artificial intelligence, and this could be a game changer in our day-to-day clinic. They are not alternative to ophthalmologist. We need to refer the specialist in right time. But at the same time, if we do the screening here using this devices, it could give us a more information. And this study, again, very interesting, done in the Filipino adults, and just which I was mentioning, photos taken from 30 centimeter from the face under normal lighting. You can see the 12 megapixel and 7 megapixel standard mobile phone cameras were being used. So almost the accuracy was 90% in 12 megapixel camera, sensitivity was 93%, and specificity was 93% too. So what we can say, it could be a future non-invasive, cost-effective screening tool, potential for large-scale diabetes risk assessment because we can use just mobile phones, and encouraging future direction for artificial intelligence assisted telehealth diagnostic. So as of now, what we can see, the role of artificial intelligence in diabetes is ubiquitous and influential. Be it the CGM data analytics, we are getting some trend of analysis or predicting hypoglycemias. Then we got automated insulin delivery. We had talked about artificial pancreas, the closed loop pumps, how we can adjust the insulin via algorithms. Then we talked about FDA cleared iLet Bionic Pancreas. Also, we had touched upon how the artificial intelligence algorithm, which can suggest insulin dose, we can use those in interpreting the CGM data and sometimes flagging the risk for clinicians. Also for patient purpose, different AI chatbots, especially the different generative artificial intelligence chatbots, we can use for patient queries, education, or clinical support documentation. I think we had one Madhu AI chatbot. The principal investigator is my good friend, Dr. Amit Dev, who had prepared that, validated that, and that was very helpful for patient, and multiple studies had validated their responses. But at the same time, we need to think about these issues critically. When we talk about human intelligence, it is about reasoning. It should have empathy, creativity, and moral judgment. But when we talk about artificial intelligence, it is data-driven task execution. It lacks consciousness, ethics, and intent. So risk is there because we are going to substitute human faculties for synthetic competence. So most importantly, what I want to mention here, when we talk about human, the E word is very important, the empathy, which is not there in AI. So for that, we need human with AI. It is not alternative, it is with. And for that, we have to look critically, especially automation bias, tendency to overtrust artificial intelligence recommendation and stop verifying independently. We can accept algorithm outputs uncritically, assuming machine is always right. So we are shifting the responsibility. Providers defer to artificial intelligence. They may say the computer suggested it instead of using own judgment. So this is a very interesting thing because now is also war time. The very intelligence we trust to automate life-saving insulin delivery can also be weaponized. Double-edged sword. We can use nuclear power for our progress, but at the same time, we can kill billions. So this is not just a glitch. This is a potential cyber lethal threat embedded in diabetes care. Just think, one of the, if our statesman have type 1D and using AID and someone hacked that AID. So attackers predict blood glucose response using machine learning. This allows creation of realistic but malicious insulin dosing commands. So these are indistinguishable from valid ones unless specifically detected. So this was again done in one study, which had been published in a very good journal of biomedical informatics. Personalized insulin dose manipulation attack and its detection using interval-based temporal patterns and machine learning algorithms. So almost 47 type 1 diabetes patients had been included, and this was a 4-year study. So it could have overdose, underdose, so children more vulnerable again. So another important area, as we are having over-reliance on artificial intelligence, that may lead to de-skilling. So erosion of clinical judgment and expertise, that is an important concern. So we have continued dependence on artificial intelligence, which can erode clinicians' own judgment and intuition. So evidence of skill atrophy, which may lead to automation bias and complacency. In diabetes, I think offloading terminology is very important. We were taught about offloading for diabetic food, but here we are talking about cognitive offloading. We are having diminished critical thinking. So critical thinking decline. We are using artificial intelligence heavily. It encourages cognitive offloading, offloading mental effort to the machine. So clinicians risk losing the habit of deep analysis. We're not doing deep analysis for the subject. Instead, grabbing quick algorithmic answers. We are less questioning why, more accepting what the ChatGPT said to me. So actually, this had been studied. This is a very good review where they had shown multiple studies. One of the very key information that I had received from this particular study, that younger participants who exhibited higher dependence on artificial intelligence tools scored lower in critical thinking compared to their older counterparts. So there is a huge concern on cognitive offloading and the future of critical thinking. Yes, there is a risk to patient autonomy and engagement as we are depending on algorithm. So there could be a possibility of algorithmic paternalism. So artificial intelligence decisions based on generalized data may override individual patient preferences. So we are talking about precision medicine by using artificial intelligence, but at the same time, we are risking a one-size-fits-all care approach. There could be a possibility of opaque logic, black box artificial intelligence tools which lack explainability. So it could be a statement like that. we might hurt patient autonomy by preventing the patient from making informed decisions over reliance on artificial intelligence. So patient could be sidelined if they cannot understand or question on artificial intelligence driven decision. And the very important part of shared decision making may suffers. Very important part, what will happen to our education system, medical education system, how we can train the next generation. So young clinicians learning with pervasive artificial intelligence may not develop robust independent decision making skill. So there is a training dilemma. So we could make doctors who become more algorithm operators. So risk of generation of doctors who are algorithm operators first and then medical problem solvers. That could be the coming second. So there is a chance. So we need to adapt medical training to emphasize critical thinking and when we should ask question to artificial intelligence. We want to prevent loss of foundational skills. We want high-tech tools, but we don't want low-tech minds. Professional implications, as we were talking, clinicians' autonomy at stake. If artificial intelligence consistently outperforms human, potentially reducing doctors' independent authority. So when an artificial intelligence guided decision leads to harm, it is unclear who is responsible. Till date, it is, yes, doctor is responsible. And that is true also. We cannot question the algorithm designer. We cannot question other people, technical people, but the clinician is accountable. We need to understand that. But there are certain legal ambiguity noted in DIY, that is do it yourself insulin systems, which raise a big question mark over who could be held liable. Value of expertise is important. If society begins to value artificial intelligence accuracy over human judgment, what will happen? Traditional expertise and intuition of clinicians could be devalued. So this is the paper which I was referring. We are not waiting do it yourself artificial pancreas system and challenges for the law. So whether it is, yes, it is an innovation, but also it could be a legal minefield. So do it yourself artificial pancreas system adoption is rising nowadays, despite no formal regulatory approval. It could involve unsanctioned integration of continuous glucose monitoring, insulin pumps, and open source artificial intelligence algorithms. So clinicians, developers, manufacturers, and users are all uncertain about their legal responsibilities. So this is the paper which suggests clinicians may be liable under clinical negligence law. I think not maybe. I think yes, they are liable under clinical negligence law. But sometimes they also make it read because they may say, as you were talking about, do it yourself. So it is the patient responsibility or the parent's responsibility or the software developer's responsibility. But those are uncertain accountability. So no clear product liability or best interest coverage for several actors. So this is the legal dilemma. Now coming to ethical implications. If we blindly follow an opaque algorithm that challenges the ethical duty of transparency and informed consent. And bias in artificial intelligence algorithms could silently perpetuate disparities without active human oversight. So, as we are talking about preserving the human element in care, that is very important. And we need to consider artificial intelligence is not equal to infallible. Maybe it will be advanced But artificial intelligence can have error, bias, or oversimplify. So human insight remains crucial to catch mistakes and tailor care. Human intelligence is irreplaceable. Clinical judgment, critical thinking, and compassion. We're talking about empathy, must not be ceded entirely to algorithms. So we need to have human intelligence. There is no alternative to that. We need to use artificial intelligence. Yes, we need to use, but as a tool, not a crutch. We need to maintain a healthy skepticism and always apply clinician oversight and context. Prioritize training and policies that harness artificial intelligence benefit while safeguarding the clinician's cognitive skills and patient's autonomy. These three pillars of ethical artificial intelligence integration in healthcare. Number one, the most important part, human in the loop system. So AI should assist, not replace. There is a role of clinical judgment. Ensure override capability and interpretability in all AI tools. We need to become AI literate. Transparent model validation, open benchmarks, and independent auditing of AI models. No black box logic in critical care settings. For an example, insulin dosing. There should not be any black box logic. And most importantly, equity first design. So design with diverse population in mind. We need to avoid systemic bias. For an example, underperformance in minority or certain pediatric data. Clinicians must not just be artificial intelligence users. They must be artificial intelligence gatekeepers. Data privacy and ethics is an important question when we are talking about artificial intelligence. And this is a very good study which had shown 81% of Android diabetes apps lacked privacy policies. Sometimes unsafe insulin dose calculators are there. Some digital twin systems align with those regulations like HIPAA or GDPR, DPDP 2025. They have AS256 encryption, pseudo-anonymization, and consent tools. But we need to be aware of these issues. These are the regulation across countries. We can see starting from US, European Union, UK, Germany, and now India, the DPDP is there. It emphasizes on consent, encryption, data sovereignty. And very recently, our article had been accepted by Bengal Physician Journal, where we try to understand the DPDP Act from the healthcare perspective, the medical researcher perspective. So we need to train future diabetologists. We need to understand artificial intelligence does not replace us, it extends us. And medical education must include data literacy, critical artificial intelligence evaluation, and the human in the loop design. So our vision should be predictive prevention at scale, national artificial intelligence diabetes registries, real-time feedback loop from different EMRs to patient devices. So to conclude, artificial intelligence is not a panacea, but it is a powerful enabler. The clinician and artificial intelligence partnerships will define the next decade. There is no doubt in that. The technology with human intelligence, not instead of it, that is very important. And when we talk about our Indian context, I think many of us know about the Rama Raksha Stotra. In the Rama Raksha Stotra, what we want? We want not only to become Vijayi, we want to become Binoyi too. So Bijoyi Binoyi Bhaved, that is our prarthana to Lord Rama. So if we use only artificial intelligence, it may make us Bijoyi. But I think many of us know that Ravana was also Bijoyi. In many war he had won, but he was not Binoyi. So we want not to become Ravana. We want to become the follower of Rama. And that is why we want both the Bijoyi and Binoyi status. And for that, we need to incorporate both the artificial intelligence and human intelligence together. Rather, human intelligence or human should be placed in the center, and artificial intelligence we need to use for providing better care, but it is not the crutch as we had mentioned. It is going to augment our healthcare delivery system. With that, I once again thank you all for giving me this opportunity to deliver this important topic. And if we have some questions or comment, we can take those. Thank you. Thank you very much.